Wound care for loved ones in a nursing facility often happens when families aren't able to be there. Families who stay involved play a big part in healing. Don't hesitate to ask the care team questions. So what should you be asking the wound care team? We came up with a list of questions for Dr. Novikov. How often should a wound be checked or reassessed, and by whom?
Frequency of wound assessment is determined how extensive the wound is, but general rule of thumb is daily assessments, with some minor wounds getting assessed 2 or 3 times a week, versus some wounds may even require more than once a week dressing change and assessment. The minor skin problems like rash may be assessed on a weekly basis and not checked more frequently.
What kind of wound is it, and what is being done to treat the underlying cause?
This is a great question to ask, and this is the wound etiology needs to be communicated across the board. We definitely make an effort to communicate throughout the nursing team, but when family members are present and they're asking this question, we applaud them because the cause of the wound, the root cause of the wound, is very, very important because of the underlying treatment plan. So it's the root cause is to be addressed in order to have best healing outcome.
What does progress look like, and how do we know if the wound is getting better or worse?
When you talk to a facility wound champion or the treatment nurse, it's great to see what kind of measurement reduction, if there is a size reduction of the wound, if there's a drainage reduction, maybe the wound that was infected at the hospital level, and then as patient is recovering, we're treating infection, and the infection is gone. These would be great goals of care, and these are something that we share with the families, and this is a great question to ask.
If the wound is not improving, what is the next step?
We get asked this question all the time. It's been asked by state surveyors and other involved professionals, as well as patients and families. Different goals for different patients. Patients at the end of life, sometimes it's unreasonable to have the full healing as the primary goal of care. Sometimes patient's comfort becomes the most and number one priority, and it's just considering overall patient's condition. It's a great goal to have. Infection prevention would be another example.
What can we expect to be done for pain management?
Both topical and systemic pain management needs to be in works. Systemic pain management is achieved by giving a pain pill, and this is something that we closely work with a primary team, a primary care physician who is attending physician at the facility. Topical pain control options is what we're useful for, what we have knowledge, and we will individualize the treatment plan to include those topical pain control options.
Once the wound heals, how do we keep it from coming back?
We get this question a lot, and this is a legitimate question. How do we prevent recurrence of the wound? We address the same risk factors, the same root causes that we identified during our initial assessment and clarified during follow-up visits. And if this is a pressure sore, there are some main factors. They may be modifiable and may not be modifiable. For example, if it's a permanent quadriplegia that's unfortunately, on a high list of pressure ulcer recurrences, we may end up having different preventive measures in place. We will be accepting this high risk. We will be providing something that's according to Medicare guidelines, patient is suitable for, such as pressure relieving mattress or other means of preventing pressure sores. Not every pressure sore is preventable.
If my loved one needs to be transferred to the hospital or rehab, how is their wound information shared?
The transfer of information between facilities is one of the biggest problems of U.S. healthcare system. We tackle this by having our progress notes, consultation notes available in a printed format, in electronic format. This can accompany patient should the wound deteriorate and require hospital assistance. Having said that, our infection rates, wound infection rates in our hands are close to zero, and wound-related hospitalization rates are also close to zero. So we barely have one week that these rates come over 1%.
What should I do to help support healing between visits?
So what should I do? And this is the question when the involved family member asks. We oftentimes come up with a great decision. Malnutrition doesn't imply any errors. You know, sometimes it accompanies end-stage dementia or other end-stage, medical conditions in elderly patients, such as malabsorption. So bringing the foods from home that's appropriate and according to the patient's prescribed diet, this would be a great choice and a great this personal touch to the patient's care for your loved one. It's not absolute requirement. We can get most of the time we can get protein supplements and needed food to provide. But sometimes, let's be honest with each other. Hospital diets are not our homemade meals. So if you can discuss with the medical team how can you add this human touch to patient recovery.